We are now going over the proning procedure. We will cover the pre-assessment prep, the actual procedure itself, and the post-procedure. Sean's going to walk us through all his assessment and the actual procedure, along with 3 other team members, making up a team of 4, and actually going from the supine position onto the prone position onto the stretcher. Sean?
So now you've done all your prep with the stretcher and you've done your medical consult. Now it's time to go in the room and you're going to do your patient assessment and get everything ready for your lines and for actually doing the turn. So the first thing is my assessment. So you're going to do your regular assessment and head-to-toe assessment, but you're going to be particularly focused on a couple things. One is you guys made a plan for sedation and paralytics, and that's going to be the first thing that you want to assess because you want to get those things moving and make sure they're adequately sedated while you do all of this. So make sure their sedation is titrated appropriately, and make sure their paralytics are titrated appropriately. Then the next thing you're going to want to focus on is on the airway itself. So a couple things you want to assess here. One is, was it verified in X-ray that it's in a good position, and is the tube still in that same position? So take a look at your depth markers right at the teeth and make sure it hasn't moved. And then also take a look at how your airway is secured and make sure it's secured very well. So either it should be a commercial device like this Thomas tube holder, or it should be tape that's not soggy and that's securing very well and goes all the way around the top of the head. If there's any doubt, then switch it out to your Thomas tube holder. That's the next thing that you're assessing is your patient's airway. Then you're going to want to think about hemodynamic status, and here you want to think about how does the patient do with fluid shifts. As you put the patient prone, there's going to be a lot of fluid shifts, so how's the patient going to tolerate that? And then what things are you going to anticipate and how are you going to react? So having some atropine ready, having some push-dose epi might be something that you want to consider. And also do you have pressors ready to go if this patient should need it? You're also going to want to think about how you're going to monitor the patient for the turn itself. As we'll go over in a minute, you're actually going to want to remove all the EKG leads off the chest because you don't want to cause breakdown. So how are you going to monitor that patient? Do they have a line that you can monitor or a pulse ox? Or another option you can do is actually put the defib pads on to monitor the patient's EKG rhythm. So that's all thinking ahead. The next thing is you want to minimize any kind of the risks for this procedure. Some of the risks for a prone patient is corneal abrasions. So since the patient is paralyzed, make sure the patient's eyes are taped. Make sure the patient has everything removed off of the patient that could potentially cause skin breakdown or anything like that. And then next thing, so my patient's ready, my sedation is good, my airway's good, I've got a plan for hemodynamics. Next thing, I'm going to actually start planning my turn. So now is the time where I'm going to remove anything that's not necessary. So if it's got IV fluid running that can be paused, I'm going to pause it, and I'm only going to keep my central drips going. Same thing with any other tubes. If I can disconnect the NG tube from suction, if I can move anything that can be removed, I remove it. If it can't be removed, you have to figure out how's it going to go in the turn. So your airway should be coming off the top of your head, and you also want to think about which way the patient is going to turn. We're going to be turning this patient towards me, so the airway, the way it is now, is going to end up under the patient's head. So it's going to go off the top, but we want to sort of flip it over to the other side, so Amber can hold it there, so that it's going to be away from the turn, right? And then the same thing with all my other lines. Other lines, the easiest place is to run them straight down the bottom of the bed. They're all the way at the bottom. Then I'm going to remove my EKG stickers. I'm going to remove the actual leads themselves and also take off the stickers because the stickers will cause breakdown, right? And then pull them off, and then the rest of my monitoring, I'm going to want it to run out the bottom so that it doesn't get tangled with anything if possible. So now my patient's ready to go as far as prepped and everything's set up where we need it to be. Now we're going to actually get ready for the move itself. So we're going to have 4 people for this turn. I'm going to have 1 person at the head. So Amber is our person who's going to be controlling all the movements because she is controlling the airway. Dennis is going to be on the hospital bed side, and then Bridget and I are going to both be on the other side. So now we're going to get our stretcher and move it here. And then a couple things I want to think about positioning. One, I want the 2 beds to be the same height. basically, or as close as I can get them. And then I want to make sure that my stretcher is positioned so that the head is going to remain right here, right at the head, and the patient's going to roll right on this roll. So right now I'm going to move this Z-Flow pillow. I'm going to put it somewhere where it's easy to get once we roll the patient. All right, so now my stretcher's ready and everything's ready. Amber's ready. Now we're going to be, and we're going to tuck the arm underneath just a little bit, because this is the way we're going to roll the patient. So we don't want the arm getting caught on anything. And now the first step will be to pull the patient to the edge of the stretcher. And Amber is going to call that, and we're going to make sure we listen to her, and it's on her count.
Okay, pulling to the edge. 1, 2, 3.
All right, so now we're at the edge of the stretcher. Now I'm going to make sure that that arm remains tucked. And then the next thing will be to pull up.
1, 2, 3.
And then we'll just keep coming down nice and slow until the patient comes right on top of this roll. And the whole time Amber is going to be controlling this head and this airway. And I can help her at this point. So I'm going to hold on to the airway and lay this down. And then she's going to take this Z-Flow pillow that's behind her. And she's going to position the head. So you can see that this is a very nice pillow. We can mold it any way we need to. So we're just going to kind of fold it in half and put it so that I can position their head up so that I can get to the airway on this side. And it's a really good position. So the next immediate thing I'm going to do is, as I'm doing this whole thing, I'm assessing their airway, but especially now I'm going to make sure that this airway is in a good position and there's no kinks in the tube or anything like that. So I'm watching that airway is good. Next thing is I'm paying attention to their hemodynamics. How's their blood pressure? How did they tolerate this turn? And once all those things are good, or if they're not good, I'm going to address them right away. Right? So if the patient becomes hypotensive, I'm going to address it. If they become bradycardic, we're going to address it. If they need airway interventions, we're going to address them right away. If everything seems good and we can leave this patient like this, then we're going to start to optimize their positioning. If they don't seem good, if despite going open my pressors, despite interventions, the patient is still unstable, or if the patient, you're concerned that you lost your airway, then at this point we would actually supinate the patient right back onto the hospital bed. Right? But say we're good, now we're going to put the patient in the ideal position. So what we want to do is we want to minimize any breakdown, and we want to put the patient in a good position that's not going to put too much stress on their joints. So we're going to leave this left arm down. It's a little bit hard to know because the patient's in a backwards position, but this is their left arm. Leave it down. I'm going to take the right arm, and we're going to actually put the right arm above their head. Right? And here's also where we got to sort of put the IVs in a good position, right? This arm doesn't bend, but really what you would end up seeing is their arm all the way on top of their head, just like this. And then we're going to take our restraint, and we're going to tie their wrist to the top of the stretcher right on this side. And that's how they're going to secure their arm. Your airway will still be in good position, and because your patient's paralyzed, even though your arm is sort of right around where the airway is, it's still safe because your patient's positioned and your IV is secured. Now I'm going to make sure they're kind of centered on the stretcher and adjust as I need to. Make sure my roll is in a good position, and then we're going to, just like Bridge is doing right now, kind of bend this knee so that it's in a good neutral position there. And then I'm pretty much in a good position, and I'm going to make sure that all my monitoring is back on in place. So put the EKG leads on the patient's back, and you can leave, if you had to put pads on, you can leave the pads where they are at this point too. And I think that's the procedure.
Just a quick review again. One person at the head of the bed will coordinate and call out the movements. You're going to have 2 people next to the ambulance stretcher and 1 person on the hospital bedside. Also remember, any participant should call stop if there's a concern or movement needs to be halted. Again, this concludes the movement of the patient from a supine to a prone position. Thank you.